A very good evening, everyone. Today we are going to discuss about the one of the main drug that is olanzapine. Olanzapine is one of the most commonly prescribed drug in our psychiatry OPD as well as IPD. So we'll be discussing about it today. My name is Dr. Shubham Chauhan, and I have completed my MBBS from AIMS Bhopal and MD Psychiatry from Lady Harding Medical College. Today we are going to have a detailed discussion about olanzapine, in which we'll be discussing about the classification, the function, its mechanism of action, the adverse effect, various combination of the olanzapine, and further topics in detail. And our source of reference will be mainly CTP, that is Comprehensive Textbook of Psychiatry, Kaplan and Sodok, Stall Prescriber Guide, Stall Prescriber Guide. Along with that, Stall Psychopharmacology, Stall Psychopharmacology. Along with this, some content we will be taking for understanding from Goodman and Gilman Pharmacology. So during the teaching, I'll be telling you the reference for everything, every possible thing. So the knowledge will be actually authentic. So you can use it anywhere, even in your OPD as well as in treating the patients. So starting with the nomenclature of olanzapine, the main olanzapine, as you all know, is a atypical antipsychotic. It's a atypical antipsychotic. According to NBN classification, what is this NBN classification? It is actually neuroscience based nomenclature. It is neuroscience based nomenclature. It is a new way of classifying the drug on the basis of their action. So olanzapine has been placed under dopamine, serotonin antagonist. The olanzapine has been placed under dopamine serotonin antagonist. In short form, it is written as dopam dopamine serotonin antagonist. Do remember this fact. Now, coming from this here, we are saying that it is dopamine serotonin antagonist. So now from here we can derive its mechanism of action. Dopamine serotonin antagonist. From here we can derive its mechanism of action. So dopamine is actually in dopamine it blocks mainly the D2 receptor, and in serotonin acts as 5-HT2A receptor antagonist and 5-HT2C receptor antagonist. Also, it acts on H1 receptor. Okay. Now, before starting all this, a bit small thing about the schizophrenia or psychosis, how actually the psychosis and psychotic symptom occurs. So for that, we need to understand the dopamine hypothesis of schizophrenia. I'm telling you this so that we can cover it from the basic, and then we can go to the advanced level of understanding the drug. So you will be able to know how the drug is actually functioning and just not does not mug up the information. So coming to the dopamine hypothesis of schizophrenia, that is F20 as per ICD-10 classification. So it can be depending upon the pathway. There are mainly five pathway. The five pathway are mesolimbic, mesocortical, to dorsolateral prefrontal cortex, mesocortical pathway to ventromedial prefrontal cortex. Do remember this fact that prefrontal cortex is actually responsible for your cognition as well as an attention. So it will be useful in it is actually responsible for the affective symptoms or good mood. The fourth pathway is the nigrostriatal pathway. Nigrostriatal pathway. And the last one is the tuberoinfundibular tuberoinfundibular pathway. See, these are it is actually dopamine hypothesis or affinity, and you should remember these pathways because then only you will be understanding the pathophysiology behind schizophrenia. So, whenever the dopamine increases in the mesolimbic pathway, it leads to positive symptoms. It's lead to positive symptoms. See, after I teach this topic, please go to Style Essential Psychopharmacology and read it. Don't just rely on my lecture. I'm just here to actually guide you and give you an overview in detail so that when you understand, when you read psychopharmacology, you understand it in a more better way. When for the symptom which are responsible through mesocortical to dorsolateral prefrontal cortex, when dopamine is found low in this, it leads to the cognitive symptoms of schizophrenia, the cognitive symptoms of schizophrenia, as well as negative symptoms of schizophrenia. See, cognitive symptoms and negative symptoms are actually different topics. This we'll be covering in detail when we'll be reading about schizophrenia. The mesocortical to ventromedial prefrontal cortex, when dopamine is low in this pathway, it leads to again affective symptoms and negative symptoms. Okay, negative symptoms. So remember this that mesocortical to prefrontal cortex is responsible for the affective symptoms, and mesocortical to dorsolateral prefrontal cortex is responsible for the cognitive symptoms. In both the pathway, when dopamine is reduced, the negative symptoms are common. In both the pathway, when dopamine is reduced, the negative symptoms are common. Coming to the neurostriatal pathway, in schizophrenia, the level of dopamine remain normal in this. So we can say that in F20, that is schizophrenia, there is not only increase in the level of dopamine and not only decrease in the level of dopamine, but there is dysregulation, dysregulation in the level of dopamine, like increased in, my dear friends, it increased in mesolimbic pathway, responsible for the positive symptoms, and decrease in mesocortical pathway. The one which project to the dorsolateral prefrontal cortex is actually responsible for the cognitive symptoms, and the one which project to the ventromedial prefrontal cortex is actually responsible for the affective symptoms. And dopamine decrease in this pathway, both of these leads to negative symptoms. So coming to this, this was an integrated dopamine hypothesis of schizophrenia. Now we will covering in detail the mechanism of action. The mechanism of action. So initially we discussed that olanzapine. How does olanzapine work? This is very important. So olanzapine works by D2 receptor blockade. I will explain you everything how D2 receptor blockade is happening and how it is helping in schizophrenia. 5-HT2A receptor antagonist, 5-HT2C receptor antagonist. Okay. So it has mainly three mechanisms: D2 receptor, 5-HT2A receptor antagonist, and 5-HT2C receptor antagonist. So olanzapine is actually working on the mainly the three receptor, that is D2 receptor, 5-HT2A, and 5-HT2C. So the receptor which are actually effective in the psychotic symptoms are D2 receptor and 5-HT2A. Do remember this, my friend? D2 receptor blockade and 5-HT2A. So by blocking the D2 receptor, what it does, it reduces the positive symptoms. where it actually blocks the D2 receptor. It blocks the D2 receptor mainly in the mesolimbic pathway. Because we saw that increase of dopamine in the mesolimbic pathway was actually responsible for the positive symptoms. So D2 blocker in the mesolimbic circuit will lead to reduction of the positive symptoms of schizophrenia, like delusion, hallucination. Okay. Now you must be curious to know how actually blockade of 5-HT2A causes decrease in psychosis. For this, you should know actually how 5-HT2A is involved in this or responsible for the psychotic symptoms. Okay. So here for psychosis, there is an indirect regulation. Serotonin is responsible for indirect regulation of mesolimbic. Do you remember? Indirect regulation of mesolimbic dopamine pathway by 5-HT2A blockade in cortex. Okay. Now we will be actually knowing, we will try to understand what is the pathway through which 5-HT2A communicate with in the cortex, communicate with the dopamine receptors in the mesolimbic. So normally what we see that there is 5-HT release, that is serotonin release in the cortex, which actually acts on 5-HT2A receptor present on glutamate projections to the dopaminergic neurons in VTA in mesolimbic tract. So what I said, that normally what we see that there is serotonin release in the cortex, which actually stimulate the 5-HT2A receptors present in the cortical glutamate projections, which lead to stimulation of dopamine neurons in the ventral tegmental area in the mesolimbic tract. So since the dopamine is getting stimulated here, dopamine receptors are getting stimulated, so again it will cause positive symptoms. It will cause positive symptoms of F20. Now, what we read is actually that olanzapine is 5-HT2A receptor antagonist. Okay, 5-HT2A receptor antagonist. So, what it will do? It will actually go and block this. It will go and block the 5-HT2A receptor present on the glutamic projection. Okay, since it will be blocking the 5-HT2A receptors, so the release of glutamate on dopaminergic neurons in VTA will be decreased, correct? Release of glutamate on dopaminergic neuron in VTA will be decreased, which will actually decrease the dopamine release in VTA. So if dopamine release is actually getting decreased in VTA, so there will be reduction in the positive symptoms. Okay, understood, my friends? So just a quick recall. What we studied, that normally we see that 5-hydroxytryptamine, that is serotonin, is normally released in the cortex, which actually stimulate the 5-HT2A receptor present in the on the glutamate projection to the dopaminergic neurons in the ventral tegmental area in mesolimbic tract, which actually causes dopamine release there and is responsible for positive symptoms. Now olanzapine comes, blocks the 5-HT2A receptor in the on the glutamate projection, decreases the further release of glutamate, which further actually decreases the stimulation of the dopaminergic neurons in the mesolimbic tract. and decreases the dopamine level, and in this way it decreases the positive symptoms of schizophrenia. Understood? Also, these key pathways, okay, do remember that 5-HT2A antagonism is actually a boon for olanzapine. How? Because it actually reduces the motor side effect, that is mainly EPS, which is more common with the first generation antipsychotic, as we remember. And at the same time, it improves the cognition and affect and negative symptoms of schizophrenia. Okay, so do remember this. Also, a very important fact to remember. This is actually very important to remember. As per CTP, if we see, it says that the affinity of olanzapine, the affinity of olanzapine for 5-HT2A is around 8 times higher than for D2 receptor. What the CTP says? That olanzapine has a higher affinity for 5-HT2A receptor as compared to D2 receptor, and it is approximately 8 times. Understood? Okay. So whatever we have studied above the neurobiology, we have studied from Stahl psychopharmacology, and now coming to the effective and cognitive, the second part of functioning of olanzapine, that is effective and cognitive modulation. We'll be starting this from the new page. Okay. So there are actually two receptors which are responsible for effective and cognitive modulation. The first one is 5-HT2A and the second one is 5-HT2C. So how does actually 5-HT2A work? So 5-HT2A, if we remember that 5-HT2A is a presynaptic. It is a presynaptic receptor on dopamine neurons in the prefrontal cortex. It's a presynaptic receptor on dopamine neuron in the prefrontal cortex. So blockade of 5-HT2A will actually lead to increase in the dopamine neurons. Okay. Here, normally, what does 5-HT2A do? It's a presynaptic receptor on the dopamine neurons in the prefrontal cortex. So, normally, serotonin act on this receptor and inhibit the dopamine release in prefrontal cortex. But when olanzapine is given, it acts as a 5-HT2A receptor antagonist and increases the dopamine release in the prefrontal cortex, which causes improvement in the cognitive symptoms as well as the affective symptoms. Now, how come 5-HT2C works? This is also important because 5-HT2C is actually a postsynaptic. Do remember this. 5-HT2A was presynaptic and 5-HT2C is postsynaptic and excitatory receptor. And where it is mainly located? It is mainly located on GABA interneuron. Where it is located? GABA interneuron. So 5-HT2C is postsynaptic and excitatory receptor, mainly located on GABA interneurons. So what normally happens? First, we will discuss the normal thing, that presence of 5-HT in the prefrontal cortex will stimulate the 5-HT2C receptor present on GABA interneurons, which will actually stimulate the release of GABA, which will actually stimulate the release of GABA. And in turn, the GABA interneurons will inhibit the release of norepinephrine and dopamine in prefrontal cortex. So release of norepinephrine and dopamine is decreased in prefrontal cortex. So because of that, what will happen? There will be low mood, there will be negative symptoms and decreased cognition. Okay. So there will be inhibition of norepinephrine and dopamine release in prefrontal cortex. Okay. Now here comes olanzapine. Olanzapine comes being a 5-HT2C receptor antagonist. What it is? 5-HT2C receptor antagonist. So it will go here, inhibit the 5-HT2C receptors where? On GABA interneurons. GABA interneurons will get inhibited. Once GABA interneurons will get inhibited, the release of GABA will be decreased. Release of GABA will be decreased. The release of decreased GABA will actually decrease the inhibition of norepinephrine and dopamine release, which actually means that there will be increased norepinephrine and dopamine release in prefrontal cortex. Do remember, my friend, again, I'm repeating this, that 5-HT2C being a 5-HT2C receptor antagonist. So it will go and inhibit the 5-HT2C receptor on the GABA interneuron. So what normally GABA interneuron do, that it releases GABA and inhibits the norepinephrine and dopamine neurons in the prefrontal cortex. Now, when we inhibit 5-HT2C, it inhibits the GABA interneurons. Inhibiting the GABA interneurons will further decrease the release of GABA on dopamine and norepinephrine neurons. So, norepinephrine neuron and dopamine neuron will be able to release dopamine and norepinephrine, thus improving the cognition as well as the effect of. Okay, understood? So, in this way, 5-HT2A receptor and 5-HT2C receptors help in improving the cognition. Okay, understood, my friend? Second, although 5-HT2C is actually good for improving the cognition, but it acts as a, see, everything has a pros and a cons, and here 5-HT2C receptor antagonism act as a cons. It's one of the what we can say disadvantages which olanzapine provides us. Why? Because 5-HT2C receptor is mainly involved in what it is involved? Is involved in promoting satiety. Involved in promoting satiety. So what happens when we give olanzapine? It blocks 5-HT2C. Once it blocks 5-HT2C, there will be no promoting of satiety. If there is no promoting of satiety, decrease satiety, what it will do? It will cause increased food intake, and this act as a factor for increase in weight gain, as the person will eat more. However, this we also this I told that olanzapine has a both and pros and cons of this receptor. So what will be the pros of this receptor? In person in which there is appetite reduction, significant appetite reduction, in this case it will be acting as a boon. So 5-HT2C receptor act has a both pros and cons. What is the pros? Pros is first, it improves the effect. Second, improves appetite. Affect and cognition, it improves appetite. useful for thin-pilled people or useful in cases where the appetite has been drastically reduced in case of depression. And what is the cons? It actually suppresses the satiety center. So it will be food, increase the food intake. Increase in food intake will be leading to weight gain. So, so this is actually a side effect of olanzapine. So we'll be remembering side effects one by one. Oh, this will be acting as a side effect of olanzapine. We'll be making a separate topic on management of side effects of antipsychotic, which will be a very different chapter, which we'll be dealing with. Now coming to third topic, that is receptor basis side effect of olanzapine. So olanzapine also acts as a H1 receptor antagonist. H1 receptor antagonist. Along with that, so what will H1 receptor antagonist do? It will cause weight gain, and at the same time it will cause sedation. How can you remember this fact? You do remember that we take cetirizine, levocetirizine. They are also 5-1 H1 receptor antagonist, and they cause sedation. In the same way, having 5 H1 receptor antagonist profile, olanzapine will be actually responsible for causing sedation. Okay, understood? By alpha 1 blockade, by alpha 1 blockade, it causes orthostatic hypotension. Although it is not one of the very prominent side effect, but yes, it is a significant effect. Okay, it will be called alpha 1 blockade. At the same time, it causes anticholinergic antagonism. What it will cause? Anticholinergic antagonism, that is M1 receptor blockade. So what will enter M1 receptor blockade will do? It will cause dry mouth, constipation, and sedation. So we need to remember things conceptually rather than just mugging up the facts. Okay, so from here we can actually deduce what are the side effects of olanzapine. The first side effect will be weight gain. The second side effect will be sedation. Third side effect will be orthostatic hypotension. Fourth side effect will be anticholinergic effect like dry mouth, constipation, and sedation. So till now we have come to know about the four side effects. Okay. Also, I forgot to tell you that there is also one more receptor which on which olanzapine acts, that is alpha 2 blockade, alpha 2 receptor. Okay, it inhibits the alpha 2 receptor. It inhibits the alpha 2 receptor in the cortical area and is responsible for improving the affective symptoms as well as negative symptoms. Okay, my friends. Now we have covered the actually whole of the mechanism of action of the different side effect, how it will be functioning in psychosis and how it will be actually improving the cognition and effect. Now we'll be coming to the part of interaction, pharmacokinetics, and pharmacodynamics. So coming to our section 2, in case of olanzapine, the pharmacokinetics and the pharmacodynamics parts. Pharmacokinetic and pharmacodynamic. So it do remember this is a bit of a you need to just cramp up it because this is more about remembrance rather than any concept will be there. Let me tell you very frankly. So first thing about olanzapine, that is it is well absorbed and its peak reaches in about 6 hours. Okay, it peaks reaches in about 6 hours. Coming to its average T half is 31 hours. If someone asks the range, it will be 21 to 54 hours. Okay. Such a long T half, so there will be some advantage of this. The advantage is that olanzapine, because of its long T half, it allows for OD dosing. It allows for OD dosing, which will be actually helpful in maintaining the compliance and decreasing the pill burden on the patient. And from this, if we deduce the steady state level of olanzapine reaches in 7 days. Steady state level reaches in 7 days. So this whole part I have taken, the reference for this part is CTP. Okay. Olanzapine is well absorbed. Peak after the oral intake, it increases to 6 hours. Average T half of olanzapine is around 31 hours, which is actually helpful in OD dosing, thus reducing the pill burden as well as the improving compliance. And its steady state level increases in the reaches in 7 days. Okay. Coming to the form and another part, metabolism part, how actually olanzapine is metabolized. So there are three important pathways. Okay, three important pathways through which it is metabolized. One is through CYP1A2, okay, which is actually major, forms the major enzyme for metabolism. The second is CYP2D6 and glucuronidation. Okay, this act as a minor pathway of metabolism of olanzapine. Okay, coming to the IM olanzapine. IM olanzapine. Do remember this? Where IM olanzapine is used in whenever there is a there is an intensely agitated patient, or when we read rapid transcoliation, there we use IM olanzapine. What is rapid transcoliation? It's a sort of actually sedating a agitated patient. I will also make a separate topic on steps of rapid transcoliation, which will be actually useful in the OPD as well as in the IPD. So in case of IM olanzapine, the peak reaches in very less time, that is only 15 to 45 minutes. 15 to 45 minutes, thus causing rapid sedation. So it is useful in agitated patient. This is also given in CTP. Okay. Coming to the drug interaction part. Coming to the drug interaction part. Okay. So make two columns. It will be helpful for you. Make two columns. On one side, write one enzyme, that is CYP1A2. That is a major enzyme responsible for the metabolism of olanzapine. And on the other side, write CYP2D6. Okay. So what we will be doing? First, we will be writing about the inducers, and the other time inhibitors. Okay. So can you give me some example of CYP inducers? See, one example which we commonly study is smoking. The second is carbamazepine. See, you will see that carbamazepine is actually commonly given, or we use it commonly in the psychiatric patient for controlling the aggression, or also as a mood stabilizer. The third will be rifampicin, anti-tubercular drug, and omeprazole, which is we use very frequently, but we don't focus much. Okay. So all these drugs are actually what? They are inducer of CYP1A2. If they are inducer of CYP1A2, they will actually increase the metabolism of olanzapine and thus decrease its level in the blood, and they decrease it by around 50%. They decrease it around by 50%. So if they're decreasing it about 50%, the olanzapine level, so the actually the function of olanzapine will reduce. So we need to increase the dose of olanzapine in such patient to get an effective response. Okay, in these patients, when they are on inducers, when they are on inducers, it will cause a decrease in the olanzapine level, which will, so in that case, we need to increase the dose of olanzapine to get the optimal effect. Okay, coming to the inhibitors of CYP1A2. A very good example is fluoxamine. Fluoxamine. So what actually fluoxamine do? It inhibits CYP1A2. So metabolism of olanzapine will decrease. Since metabolism of olanzapine will decrease, its serum level will increase, and its serum level increases by around 50 to 100%. The reference for this is CTP and stall. Okay, the reference for this is CTP and stall. The level of olanzapine increases by 50 to 100%. And in this case, now we have to decrease the level of olanzapine. Why? Otherwise, it will cause increased side effect. Otherwise, it will cause increased side effect. Okay. This much understood. The last will be actually summarizing it in 10 minutes so that you can have a quick recall. Now coming to the, I know it's a bit big lecture, but we are dealing with the concepts. Now coming to the therapeutic indication. Coming to the therapeutic indication and its efficacy. Okay. So first we'll write FDA approval, and then we'll be writing the off-label use. What is the off-label use? So first point for first FDA approval is for schizophrenia. Okay, both in acute management as well as in maintenance phase. Both in acute management as well as in maintenance phase. The second is in bipolar mania or mixed state. Here the FDA guideline says that it can be used as a monotherapy. It can be used as a monotherapy or as an adjunct to valproate or lithium. Okay, so this is second indication. Now coming to the third indication, in bipolar type 1 depression. In bipolar type 1 depression. Here it is FDA approved only in fixed dose combination. Only in fixed dose combination along with fluoxetine. That is olanzapine fluoxetine combination. Why it is useful in bipolar depression? See, here olanzapine will act as a mood stabilizer. First. Second, it will prevent switching by acting as mood stabilizer, preventing switching from depression to manic symptom. And the third, through 5-HT2A and 5-HT2C antagonism, 5-HT2A and 5-HT2C antagonism, it will actually improve the cognitive symptoms in depression as well as improve low mood. Coming to the fluoxetine part, we'll have a separate lecture on fluoxetine, but a short how it is acting in depression. First, fluoxetine is an SSRI. Fluoxetine is an SSRI. Also, it's also an antidepressant with an additional 5-HT2C receptor antagonist property. 5-HT2C receptor antagonist property. Okay. This is given in Stahl. You can read it from there. Stahl Essential Psychopharmacology. Thus, improving the cognitive symptoms and the low mood. Okay. Now, coming to the fourth, in FDA approved indication, it is useful in treatment-resistant depression. Okay. In treatment-resistant depression in the form of olanzapine fluoxetine combination. Okay. Now, the fifth is acute agitation in schizophrenia or bipolar mania. In the how, in which form? In IM form. What we read earlier, that its peak action is within 15 to 45 minutes. So it will be very useful in acute agitation in schizophrenia and bipolar mania. Okay. So there are total five. If we see, there are total five FDA approved indication. The first one is schizophrenia, both in acute as well as in the maintenance phase. Second one is bipolar mania or mixed state, in which it is useful in the monotherapy or as an adjunct to valproate or lithium. The third one is bipolar 1 depression, used as a fixed dose combination in olanzapine fluoxetine combination. In case of TRD, treatment resistant depression, as olanzapine fluoxetine combination. And it is useful in case of controlling acute agitation, both in schizophrenia as well as in bipolar mania, in the form in IM form. Okay. Coming to the clinical efficacy part. Coming to the clinical efficacy part. So this is actually important. Okay. How its clinical efficacy was established? You remember one of the important trial, that is KT trial. Okay. KT trial is an important trial. What we saw, it is a landmark trial which actually held for olanzapine as one of the GOAT drugs. One of the GOAT drugs. Okay. What we came to know about olanzapine in KT trial, that it has the longest time to discontinuation. Okay. In KT trial, it was found that in case of olanzapine, among all drugs, olanzapine had the longest time to discontinuation, which meant that it had high effectiveness, or we can say highest effectiveness in those set of drugs used. But a negative thing which was found in that among those drugs, it has the worst metabolic profile. It has the worst metabolic profile. Okay. So we'll be having a separate lecture on KT trial also. See, I'm not just saying it, we will be making a separate lecture on KT trial. It's actually one of the most important trial which we need to read for our even university exams, as well as for understanding, better understanding of the first generation and the second generation and the psychotic, how they evolve throughout the time, the cost efficacy, as well as the functional efficacy, for which it is important. Okay. Now, olanzapine is superior to haloperidol mainly. We are talking about the first generation antipsychotic in terms of negative symptoms as well as the total pathology scores, which we actually calculate in terms of PANSS. Okay. Also, olanzapine is useful as an adjunct in catatonia. Okay. Understood? Also useful in treatment resistant schizophrenia or treatment resistant bipolar disorders. Okay. Its effectivity is also seen in opioid induced hypoactive delirium, but at low dose. What is the low dose? That is 2.5 mg. What is the low dose? 2.5 mg. So it is also useful in opioid-induced hypoactive delirium. So this it is given in CTP, and you can go and read it from there. So also I was going to tell about the off-label use, which I didn't tell earlier. Okay, we only talked about the FDA-approved use. Now coming to the off-label use, the first off-label use in other psychotic disorder like psychosis and NOS or unspecified non-organic psychosis or schizoaffective disorder. It is useful for controlling the behavioral disorders. Behavioral disorder. In which cases, rather than saying disorder, I'm sorry, it should be behavioral disturbance. It should not. It should be behavioral disturbance. So in which case it will be useful in controlling behavioral disturbance. First, in case of dementia, controlling the BPSD symptoms. Second, in case of children and adolescents, and children and adolescents. Okay. Third, it is useful in controlling impulse control. Okay, disorders. The third off-label indication is borderline personality disorder, and the fourth is PTSD. Okay, so there will be four off-label use. The first will be other psychotic disorder like unspecified non-organic psychosis, schizotypal, schizoaffective. The second is behavioral disturbance, which will be mainly useful in patient of dementia, in controlling behavioral disturbance in dementia, children and adolescent in impulse control disorder. The third will be bipolar, borderline personality disorder, and the fourth is PTSD. Okay. Now coming to the dosing and the administration. Okay. Dosing and administration part. Coming to the dosing and administration form. So it is available in actually four forms. First is oral tablets. Second is oral disintegrating tablets. Third one is short acting IM. And the fourth one is LAI, long acting injectable. Okay. In India, it is most famously known as Tolas. So for there are olanzapine is available as oral tablet, oral disintegrating tablet, short acting IM, and in the form of LAI. So after this, we are coming to the oral dosing. What are the oral dosing of what is the oral dosing of olanzapine? So the minimum coming from Maudsley, if you read Maudsley, minimum effective dose, minimum effective dose of olanzapine in first episode and in multiple episode. In first episode, the dose is 5 mg. Okay. And multiple episode, it is 7.5 mg. Okay. Oral dosing, the minimum effective dose of olanzapine in first episode is 5 mg, and in multiple episode it is 7.5 mg. And the maximum dose, maximum FDA approved dose is maximum FDA approved dose is 20 mg per day. As per CTP, it is given that we can increase the dose of olanzapine by 5 mg per week. 5 mg work week per week. Okay. However, sometimes it's also seen that in case of refractory schizophrenia, sometimes we can increase the dose of olanzapine to 520 to 30 mg per day. But it is only on the clinical decision of the clinician as well as seeing the metabolic profile, as well as the side effects, as well as the EPS. Okay. Coming to the dosing of olanzapine fluoxetine combination. So in India, if we see, olanzapine is available in form of 5 mg, 10 mg, 2.5 mg, 5 mg, 10 mg, 20 mg, and fluoxetine is available in forms of capsules, 10 mg capsules, 20 mg, 40 and 60. So we can give in a combination. The typical maximum dose, which is given in CTP is 18 mg of olanzapine and 75 mg of fluoxetine. Okay, given in install and CTP both. Coming to short acting, IM, it is available as ampule of 5 mg per ml, and each ampule consists of 2 ml. So each ampule consists of total of 10 mg. Understood? Okay. So initially we will give 10 mg if the patient is agitated, and even after, if it is not getting controlled, then after 2 hours we can give extra 5 to 10 mg. Okay. Each vial contains concentration of 5 mg per ml, and each vial contains 2 ml. So a total of 10 mg in a single vial. In case of acute agitation, we will be giving 10 mg. We'll wait for 2 hours, and if the patient is not getting controlled, then again we'll giving 5 to 10 mg. But the maximum dose which we can give IM is 20 mg per day here also. Okay, 20 mg per day here also. Also, do remember that no more than 3 injection. No more than 3 injections should be given. One important point to remember here is very important point. It is mentioned actually in CTP that never combine, not never combine, avoid. Okay, what avoid? What you should avoid with IM olanzapine? You should avoid IM benzodiazepine. Okay, why? Because IM benzodiazepine plus IM olanzapine can precipitate respiratory depression. Can precipitate respiratory depression. If at all, if you want to combine IM benzodiazepine, so keep a separation of greater than 1 hour. Keep greater than or equal to 1 hour separation between both the dosing so that we can avoid respiratory depression. Okay. So coming to LAI. So LAI, the constituent is actually olanzapine palmoate. Olanzapine palmoate. Okay. So LAI is available in actually 3 strengths. In how many strength? 3 strength. That is 200 mg, 300 mg, and 405 mg. 300 mg, 210 mg, 300 mg, and 405 mg. After giving LAI, it is very important. Okay. After giving LAI, it is very important that there should be a 3 hour mandatory post injection observation. Okay. You must be thinking why I'm not talking in detail about LAI. So LAI is itself a very big topic, so we will not be covering here. We are making a separate lecture on LAI of olanzapine. There we will be discussing the regimen, how it is acting, what is the peak level, what is the T half, and then we'll be discussing further. Coming to the one of the black box warning of LAI is PDSS. What is PDSS? That is injection, post injection delirium sedation syndrome. What it is? Post injection delirium sedation syndrome. So what it is prevalence? First, what is the incidence of PDSS? So the incidence of PDSS is actually less than 0.1%. Okay. Do remember this fact? Less than 0.1% given in CTP. Okay. Less than 0.1%. 0.1%. Okay. Understood? So from here, only a bit of topic is left. So a bit of more patience you require here. Coming to the adverse effect. Okay. Coming to the adverse effect. So the adverse effect, first the adverse effect will be dividing it into metabolic, neurological, cardiovascular, and other risk. Okay. In case of metabolic, if we see, the first one is, so coming in case of the metabolic side effect, the first one will be actually weight gain. It is highest among all antipsychotic along with clozapine. Okay. First one is weight gain. Weight gain. The second one is dyslipidemia. Second one is dyslipidemia. What it causes in dyslipidemia? It actually increases all. It increases triglyceride, it increases LDL, it increases cholesterol. Okay. And the third one is it causes diabetes mellitus, insulin resistance, and increases the risk of diabetic ketoacidosis. So since it increases the risk of diabetic ketoacidosis, so it is one of the life-threatening side effect. Okay, we'll be dealing with the life-threatening side effect also. So it is one of the life-threatening side effect. Understood? Coming to the neurological side effect. Neurological side effect. The first one is sedation due to anticholinergic side effect as well as the H1 receptor antagonist. Second will be EPS. However, it is uncommon. Okay. Thanks to the 5-HT2A receptor antagonist property. So it is mainly a sparing EPS sparing drug. And the third one is TD. However, the risk is very low. The risk is very low. The risk is low. Okay. The third effect, the third side effect is actually cardiovascular side effect. In cardiovascular side effect, it causes orthostatic hypotension. We read about this earlier. Why? Which receptor? Alpha 1 blockade. Which receptor? Alpha 1 blockade. Second one is when it is given IM. Okay. When it is given IM, immediately it can cause hypotension or bradycardia. It can cause bradycardia. Okay. Coming to the other risk which it can cause, other risk which olanzapine can cause is, which is very rare actually, it is stress reaction, increased liver enzymes, And this is very important. Black box warning. Black box warning. This is almost same for all antipsychotics. That is, it increases mortality. Do remember this, it increases mortality in elderly with dementia related psychosis. Okay, do remember this black box warning. It's actually common for all antipsychotic, that is increased mortality in elderly with dementia related psychosis. Okay, so coming to the monitoring requirement. So we'll be studying this in detail in another lecture. We will be dealing the monitoring of various parameters which were required in patients who are given antipsychotics. Okay, this will be dealt in a separate lecture. Coming to special population. Special population. Now, special population includes child, elderly, and pregnant and breastfeeding females. In case of child, it is seen that schizophrenia is approved for greater than or equal to 13 years for schizophrenia. Olanzapine is approved for greater than equal for children with greater than equal to 13 years for schizophrenia. Okay. BPED mania for greater than equal to 13 years. But this is important to remember this. In case of bipolar depression, okay, in case of bipolar depression, along with fluoxetine, in case of bipolar depression, along with fluoxetine, it is approved for greater than or equal to 10 year of age of child. Understood? So in case of children, children, it is approved for schizophrenia as well as bipolar affective disorder for children of age greater than equal to 13 years. While in case of bipolar depression, along with combination with fluoxetine, it is approved for greater than equal to 10 years of child. Okay. Coming in elderly, since elderly are very sensitive to any drug because of the super sensitization of the receptors. So usually we start olanzapine in less than 5 mg per day. Okay, we start in less than 5 mg per day. We try to avoid LAI as much as possible. Why we do so? Because they have increased sensitivity. I told you there is hypersensitization of receptor in old age. You can go and read about this from Oxford textbook of geriatric psychiatry or neuropsychiatry. It is given very well what is the reason of supersensitization of receptors in old age. Okay, it is given in Oxford textbook of old age. They increase the sensitivity to sedation and hypotension. Okay, so in case of elderly, we should start with less than 5 mg per day, and we should avoid LAI, that is increases sensitivity to sedation and orthostatic hypotension. Coming to breastfeeding in case of breastfeeding and pregnancy. So olanzapine is comparatively safe in pregnancy. Okay, it belongs to category C. Okay, however, there is a problem in case of using olanzapine, that it increases the risk of gestational diabetes mellitus. It increases the risk of gestational diabetes mellitus. Also, it can cause macrosomia in baby. It can cause macrosomia in baby. Talking about breastfeeding, it is safe in breastfeeding as only 1% of maternal dose, as only 1% of maternal dose reaches the breast milk, so very less amount. So mm, a drug is considered to be safer till the amount of drug in the breast milk is less than 10% of the maternal dose. So only 1%, around 1% of maternal dose reaches the breast milk. Okay, so it is actually safe in breastfeeding. However, the child must be watched for side effect, which is mainly sedation. Okay, coming to another special population, that is in case of hepatic and renal impairment. Coming to another population, that is hepatic and renal impairment. So in case of hepatic impairment, since it is mainly metabolized by the liver, we can actually start with a low dose of 5 mg per day. Okay. In case of renal impairment, in case of renal impairment, if we see by US label, okay, if we see by US label, it says that no change in dosing is required. No change in dosing is required. Okay. However, as per UK guidelines, UK guidelines suggests a reduction in dose. Suggest a reduction in dose. Okay. Now coming to the role of olanzapine in case in terms of combination and augmentation. Combination and augmentation. So divide the page in two parts. How it is used in combination, and the second when it is used as augmenting agent. In combination, it is used already we have studied as olanzapine fluoxetine combination, and the second combination which is olanzapine plus semidorphan. Olanzapine and semidorphan. You know the mechanism of olanzapine that is that is useful in a case of treating psychosis. Semidorphan is actually a mu opioid receptor antagonist. Okay. So what is the use of semidorphan here? Since it is a mu opioid receptor antagonist, so it actually reduces weight gain. So mainly it is combined with olanzapine to reduce the risk of weight gain due to olanzapine. However, do remember that it does not completely eliminate the risk of weight gain. Okay. One thing about this olanzapine semidorphan combination is that it is contraindicated. So where it can be contraindicated? Just think conceptually. It's a mu opioid receptor antagonist. So it will be contraindicated in opioid users. Contraindicated in opioid users. Why? It can precipitate withdrawal. Okay, understood. So two combination, olanzapine fluoxetine combination, and the second one is olanzapine semidorphan combination. Semidorphan is a mu opioid receptor antagonist, so it reduces the risk of weight gain. However, it does not completely eliminate the weight gain due to olanzapine. One contraindication to this combination is actually opioid users, chronic opioid user, because if we give this, semidorphan will go and block the receptors and it will precipitate withdrawal. As augmenting agent, if we see, it is useful in augmentation in case of treatment-resistant depression. Also FDA approved along with fluoxetine. Second, for agitation and as an adjunct in bipolar disorder, okay, along with lithium and valproate. Understood, my friends? Okay. So coming to the end part, so TDM, when is actually TDM required in olanzapine? So if you ask me normally, it is not required because its therapeutic level is not so fluctuating and it's a broad therapeutic level. However, there are few conditions where TDM is actually strongly recommended. TDM is strongly recommended. But for TDM, we should know what is the actually the therapeutic range. What is the therapeutic range of olanzapine? So the therapeutic range of olanzapine is 20 to 80 nanogram per ml. What is the therapeutic range? 20 to 80 nanogram per ml. Understood, my friends? See, this is actually a broad therapeutic range. So usually TDM is not required. So when TDM will be required? In which cases? First, it will be when there is non-response to olanzapine. Second is poor tolerability. Third is smokers, chronic smokers or increased smoking or CYP1A2 changes caused by drugs. Okay. And in case of suspected non-adherence. Usually we don't require TDM, but if someone asks that when it is required, you can quote these four things, and these are from reliable sources. Okay. And at what therapeutic level certain side effect occurs. So if we see on greater than 20 microgram per liter, it causes weight gain. Okay. If there is a poor response, if there is a poor response and the level is less than 20, then what we will do? We'll increase the dose. Okay. And if there is good response, if there is good response plus but side effects are present. Okay. So the target should be, what should be the target? Less than 40 nanogram per ml. Okay. Less than 20 nanogram per ml. Okay. So three you can remember is three good important points. If actually the level is greater than 20 nanogram or nanogram per ml or microgram per liter, then it increases the risk of weight gain. In second scenario, if there is poor response but the level is less than 20 nanogram per ml, it increase the dose. And the third is when there is good response but side effects are present, the target dose should be the target therapeutic level should be less than 40 nanogram per ml. Okay. So with this, we'll be ending up our lecture of olanzapine. So actually, it is a broad lecture, but do remember that it is not a replacement of your books. After completing this, after reading this lecture, you can make notes, but go back and reinstall essential psychopharmacology as well as CTP, which will help in actually retaining you the concepts, as well as this video is actually not a replacement for the books, because I will again emphasize that books are going to be the building block of your psychiatry. Thank you. If you like the content, follow the channel, share and subscribe, and comment in the section box that which more topics you want in detail. Okay, thank you so much.